Good day everyone. It is nice to see you again. Welcome to our Any Learning, as our learning community. Lesson 3. Care of clients under emergency situation. Environmental emergencies. Increased interest in outdoor activities such as running, hiking, cycling, skiing, and swimming has increased the number of environmental emergencies seen in the emergency department. Illness or injury may be caused by the activity, exposure to weather, or attack from various animals or humans. Some examples of environmental emergencies are the following. 1. Heat cramps. 2. Heat exhaustion. 3. Heat stroke. 4. Frostbite. 5. Hypothermia. 6. Submersion injuries. 7. Stings and bites. 8. Airway obstruction. 9. Injuries to bones and joints. And 10. Abdominal injuries. Heat cramps. Heat cramps are caused by the loss of body salts, fluid and electrolytes during sweating. Low salt levels in muscles cause painful cramps. Heat cramps are severe cramps in large muscle groups fatigued by heavy work. Cramps are brief and intense, and tend to occur during rest after exercise or heavy labor. During assessment, you can observe the following to the patient: nausea, tachycardia, pallor, weakness, profuse diaphoresis, muscle spasms, and pain usually in abdomen, arms, or legs. Interventions include the following. Cramps resolve rapidly with rest and oral or parenteral replacement of sodium and water. Elevation, gentle massage, and analgesia minimize pain associated with heat cramps. Instruct the patient to avoid strenuous activity for at least 12 hours. Discharge teaching should emphasize salt replacement during strenuous exercise in hot, humid environments. You can also recommend the use of commercially prepared electrolyte solutions, for instance, sports drinks. Heat exhaustion. Prolonged exposure to heat over hours or days leads to heat exhaustion. Heat exhaustion is the body's response to loss of water and salt from heavy sweating. During assessment, you can observe the following to the patient: fatigue, nausea, vomiting, extreme thirst, feelings of anxiety, hypertension, tachycardia, elevated body temperature, dilated pupils, mild confusion, ashen color, and profuse diaphoresis. Interventions for heat exhaustion are the following. Begin treatment by placing the patient in a cool area and removing constrictive clothing. Monitor the patient for airway, breathing, circulation, including cardiac dysrhythmias caused by electrolyte imbalances. Initiate oral fluid and electrolyte replacement unless the patient is nauseated. Do not use salt tablets because of potential gastric irritation and hyponatremia. Initiate a 0.9% normal saline intravenous solution. If oral solutions are not tolerated, an initial fluid bolus may be needed to correct hypotension. Place a moist sheet over the patient to decrease core temperature through evaporative heat loss. Consider hospital admission for the older adult, the chronically ill, or those who do not improve within 3 to 4 hours. Heat stroke. Heat stroke, the most serious form of heat stress, results from failure of the hypothalamic thermoregulatory processes. It is a medical emergency. The patient has a core temperature greater than 104 degrees Fahrenheit or 40 degrees Celsius and increases rapidly within 10 to 15 minutes. Death from heat stroke is directly related to the amount of time that the patient's body temperature remains elevated. Signs and symptoms are the following: increased sweating, vasodilation, and increased respiratory rate. The body's attempt to lower temperature, deplete fluids and electrolytes, specifically sodium. Altered mentation, circulatory collapse, skin is hot and ashen, and neurologic symptoms such as hallucinations and loss of muscle coordination. Take note of this one. Monitor the patient for signs of rhabdomyolysis, a serious syndrome caused by the breakdown of skeletal muscle. The muscle breakdown leads to myoglobinuria, which places the kidneys at risk for acute kidney injury. Carefully monitor the urine for color, for instance, tea-colored, amount, pH, and myoglobin. First aid and interventions for heat stroke are the following. Place worker in shady cool area. Loosen clothing. Remove outer clothing. Fan air on worker. Cold packs in armpits. Stabilizing the patient's airway, breathing, circulation and rapidly reducing the core temperature. Administration of 100% oxygen compensates for the patient's hypermetabolic state. Ventilation with a back valve mask or intubation and mechanical ventilation may be required. Correct fluid and electrolyte imbalances. Initiate continuous ECG monitoring for dysrhythmias. Various cooling methods are available, such as removing clothing, covering with wet sheets, and placing the patient in front of a large fan. Evaporative cooling, immersing the patient in a cool water bath, conductive cooling, and administering cool fluids. Aggressive temperature reduction should continue until core temperature reaches 102 degrees Fahrenheit or 38.9 degrees Celsius. Patient and caregiver teaching focuses on how to avoid future problems. Provide essential information regarding proper hydration during hot weather and physical exercise. Instruct patients on the early signs of and interventions for heat-related stress. Take note. Closely monitor the patient's temperature and control shivering. Shivering increases core temperature because of the associated heat generated by muscle activity and complicates cooling efforts. Chlorpromazine, thorazine, IV is the drug of choice to control shivering. Antipyretics are not effective in this situation because the elevated temperature is not related to infection. Frostbite. Frostbite is true tissue freezing that results in the formation of ice crystals in the tissues and cells. Peripheral vasoconstriction is the initial response to cold stress and results in a decrease in blood flow and vascular stasis. We have two types of frostbite. 1. Superficial frostbite, and 2. Deep frostbite. Superficial frostbite. It involves skin and subcutaneous tissue, usually the ears, nose, fingers, and toes. The skin appearance ranges from waxy pale yellow to blue to mottled, and the skin feels crunchy and frozen. The patient may complain of tingling, numbness, or a burning sensation. Handle the area carefully and never squeeze, massage, or scrub the injured tissue, because it is easily damaged. Remove clothing and jewelry, because they may constrict the extremity and decrease circulation. Immerse the affected area in a water bath, 98.6 degrees to 104 degrees Fahrenheit, or 37 degrees to 40 degrees Celsius. The blister should be debrided and a sterile dressing applied. Avoid heavy blankets and clothing because friction and weight can lead to sloughing of damaged tissue. Administer analgesia and tetanus prophylaxis. Deep frostbite. It involves muscle, bone, and tendon. The skin is white, hard, and insensitive to touch. The area has the appearance of deep thermal injury with mottling gradually progressing to gangrene. The affected extremity is immersed in a circulating water bath, 98.6 degrees to 104 degrees Fahrenheit, or 37 degrees to 40 degrees Celsius. After a warming, the extremity should be elevated to reduce edema. Intravenous analgesia is required in severe frostbite because of the pain associated with tissue thawing. Provide tetanus prophylaxis. Amputation may be required if the injured area isn't treated or treatment is unsuccessful. Hypothermia. Hypothermia, defined as a core temperature below 95 degrees Fahrenheit or 35 degrees Celsius, occurs when heat produced by the body cannot compensate for heat lost to the environment. Wet clothing increases evaporative heat loss to 5 times greater than normal. Immersion in cold water, for instance, near drowning. Older adults are more prone to hypothermia because of decreased body fat and diminished body's response. We have 3 types of hypothermia. 1. Mild hypothermia. 2. Moderate hypothermia. And 3. Severe hypothermia. Mild hypothermia. Temperature is ranging from 93.2 degrees to 96.8 degrees Fahrenheit or 34 degrees to 36 degrees Celsius. Usually have shivering, lethargy, confusion, rational to irrational behavior, and minor heart rate changes. Moderate hypothermia. Temperature is ranging from 86 degrees to 93.2 degrees Fahrenheit or 30 degrees to 34 degrees Celsius. It causes rigidity, bradycardia, slowed respiratory rate, BP obtainable only by Doppler, metabolic, and respiratory acidosis, and hypovolemia. Severe hypothermia. Temperature is at or below 86 degrees Fahrenheit or 30 degrees Celsius, makes the person appear dead, and is a potentially life-threatening situation. Metabolic rate, heart rate, and respirations are so slow that they may be difficult to detect. Reflexes are absent, and the pupils fixed and dilated. Profound bradycardia, ventricular fibrillation, or a systole may be present. Every effort is made to warm the patient to at least 86 degrees Fahrenheit or 30 degrees Celsius before the person is pronounced dead. Cold blood becomes thick and acts as a thrombus, placing the patient at risk for stroke, myocardial infarction, pulmonary emboli, and renal failure. Interventions for hypothermia are the following: managing and maintaining airway, breathing, circulation, rewarming the patient, correcting dehydration and acidosis. Rewarming places the patient at risk for afterdrop, a further drop in core temperature. This occurs when cold peripheral blood returns to the central circulation. Rewarming shock can produce hypotension and dysrhythmias. Thus, patients with moderate to severe hypothermia should have the core warmed before the extremities. Discontinue active rewarming once the core temperature reaches 89.6 degrees to 93.2 degrees Fahrenheit or 32 degrees to 34 degrees Celsius. Treating cardiac dysrhythmias. Patient teaching focuses on how to avoid future cold-related problems. Essential information includes dressing in layers for cold weather, covering the head, carrying high carbohydrate foods for extra calories, and developing a plan for survival should an injury occur. Kindly click the next button for part 2. Thank you for listening. Have a good day and be safe. Agyamanag.